Thank you, Pardeshi sir. It's my privilege to introduce the next chairperson for today, Dr. Bharti Maheshwari. Madam is the professor and head at the Muzaffarnagar Medical College. She's been chairperson for the Proxy MTP committee in the past, as I've already said. She's a governing council member of ICOG, just like I am, and she's been secretary of UPCOG. In that capacity, she has organized so many conferences and spread the word regarding preventing maternal mortality and improving women's health. She's done commendable work in the MTP committee, of course. She's published papers and review articles in several index journals. She's also been the person who delivered the Kamini Rao Yuva Foxy oration from the North Zone. Welcome, Dr. Bharti Maheshwari, madam. The stage is all yours. I request you to introduce our distinguished speaker, Dr. Suchitra.
Thank you, Dr. Pratik Tambe. First of all, I would like to thank and congratulate you as the EMOX Endocrinology Committee on this webinar. Thank you for inviting me. And definitely, it's a very important topic, preeclampsia and eclampsia, hypertensive disorder of pregnancy. They always remain challenges for all of us. For last 20 years, many things are researches are done, lots of work has been done for pathophysiology, for the management, prediction, diagnosis. Still, we are doing. So, my greetings and namaskar to Dr. Padresi sir, EMOX President, Dr. Sujata, and of course, speaker, Dr. Shamila. She has really, I was mesmerized by her talk, that how she has, then I was just flowing in her talks and her PPT. That was really a good perspective she has kept pre-eclampsia. And now I am really, it's my honor to introduce the next speaker, none other than Dr. Suchitra Pandit. She is the past president of Foxy. And we all know it. And not only this, that as a past president, we all know her as a very good, humble, and very sweet human beings, always very encouraging for her juniors. And we all know that she is President ISOPAB also 2018 to 20, President of Gestosis, has done a very good job, and we have attended her lots of conferences organized by her in 2015 to 18, and Foxy and ICOG President, of course, 14-15, Foxy representative of AOFOG 15 to 70s, and she has chaired the CEFOG Medical Education Committee. She is the President MOX, Professor and Unit Chief as medical colleges in the Mumbai, and have done lots of publications, books, and lots of adolescent empower projects and other things. So now I'm not coming in between you and Dr. Suchitra Pandit. Dr. Suchitra Pandit is going to deliver a very important part of pre-hypertensive disorder of pregnancy, that is eclampsia, how to prevent morbidity and mortality. So, madam, we are just curious to hear you. Dr. Suchitra Pandit, madam.
Thank you so much, Dr. Bharti. Thanks to Pratik for giving me this opportunity, and hello to Rajendra Pardesi and Dr. Sujata, President and Secretary of EMOX. Can I just share screen?
Yes, ma'am. Please go ahead.
Yeah. Yeah. Is it there?
Yes.
Is it there?
Yes, ma'am. Please go full screen.
Yeah.
This is actually full screen only. Okay, I'll just try again once more.
If you can hit F5 on the keyboard.
Yeah. Is it okay now?
Perfect. Yeah. Perfect. Yes.
Okay. So, after that wonderful lecture by Charmila in the changing landscape, we will move on to eclampsia. Of course, I would like to mention before I start off that through the Gestosis India Association, we have the Gestosis score, and that is something, in the low to middle income countries, we can use the Gestosis score to predict. If you have that score of 3 or 4, then obviously you start off with low dose aspirin, and then of course when a patient has access to ultrasound, you do the first trimester scan along with the dual marker and the AVCO screen, you probably get a better predictability. But where this is not possible, come se come, the Gestosis score is a great tool, and it has been validated by Dr. Meeta from Jammu. It is already published in the Jogi. And please start using the Gestosis score. It is available on the Android phone. You have to download it from the Play Store and use that. It's useful for the general public. My topic for today is eclampsia, preventing maternal morbidity and mortality. And as we all know that eclampsia is considered as a complication of severe preeclampsia, and it is commonly defined as a new onset of grand mal seizures as well as unexplained coma which can occur during pregnancy or the postpartum period. And sometimes there may be no signs and symptoms of preeclampsia, but most of the time there will be a form of preeclampsia. It occurs during or after the 20th week of gestation or in the postpartum period. And remember, 10% of all pregnancies are complicated by hypertension, and preeclampsia and eclampsia account for about half of these cases globally. And these conditions have been recognized and described for years, despite a complete lack of understanding. More and more and more is known about it over the years. Way back in 5th century, Hippocrates had noted that headaches and convulsions, along with drowsiness, were ominous signs which were associated with pregnancy. And in 1619, Verandis had coined the term eclampsia so that people should start using this term. Now, the definition of preeclampsia, as Charmila has very rightly pointed out, no longer includes proteinuria, because you see the advanced disease even before the proteinuria. So I won't go back into the definition as she's already done that. But eclampsia is defined as a new onset of generalized tonic-clonic seizures in a woman with preeclampsia, may or may not be, which typically lasts for 60 to 90 seconds in duration. And eclamptic seizures can occur antepartum, 20 weeks after gestation, intrapartum, or even postpartum. And seizures before 20 weeks are rare, but they have been documented in women with gestational trophoblastic disease. So exact etiology is still unclear, but probably the two mechanisms which are being proposed, adding to the newer ones which are coming up, as it is abnormal placentation, as now Charmila has pointed out that the cardiovascular problems pre-existing in these women can also cause a complication. But however, we just need to know that there is an inadequate invasion of the cytotrophoblast which lead to poor remodeling of spiral arteries. This reduces the blood supply to the placenta, and abnormal blood supply leads to the increased uterine artery resistance, vasoconstriction, and finally ischemia and oxidative stress. And probably this is the basis of all the predictors where the free radicals, the cytokines, the VEGF, and all the pro-inflammatory proteins and angiogenic proteins are looked at. And on the basis of the blood test, you're able to predict women who are going to have that severe preeclampsia, and you can prevent that so that you don't go on to eclampsia. The second proposed mechanism is that elevated blood pressure from preeclampsia causes dysfunction of the autoregulation of the cerebral vasculature. This causes a hypoperfusion, endothelial damage, or edema. So whatever be the mechanism, today when we see eclampsia, we know that it can occur more commonly antepartum, and usually most of the cases will get it after 28 weeks. And the post-ictal state, which is often present after seizure activity, people can have warning symptoms such as headaches, visual changes, abdominal pain, and increased BP before the onset of the seizure activity. And there's a whole lot of differential diagnosis which comes on. Of course, as clinicians and obstetricians, we know what eclampsia is, and sometimes we are able to make out that this is not probably due to a brain trauma or a ruptured aneurysm. However, we need to keep in mind that chronic renal disease, chronic hypertension, primary seizure disorders, gallbladder disease, the APLA syndromes, the hemolytic uremic syndrome, pancreatic disease, ITPs, there are toxins, and there are situations like intracranial hemorrhage, brain tumors, and stroke, which can mimic convulsions in pregnancy, and therefore we have to watch out. So I'll begin with just a case and then go on to what is the management of eclampsia. This is a 19-year-old pramigravida at 36 weeks of gestation. She's been to hospital only thrice for antenatal checkup, and finally she moves over to a fourth hospital because that's her mother's place. A common thing where girls go in their mother's place for delivery. And she's been brought in an altered state of consciousness with a history of one episode of convulsions at home. In the labor ward, her BP is 220 by 140, and she has 3 pluses of proteinuria. She is not in labor. So what are the principles of care? Obviously, acute management is left lateral position, airway, so what we call as a mouth gag earlier, and oxygen, and seizure prophylaxis with magnesium sulfate, Fluid monitoring and restrictions, obviously seek IV, cannulation, and 2 arms is always better. Start off an antihypertensive therapy and simultaneously do an investigation and then consider a delivery. So this is the chart we had developed at the HDP consensus meeting. And we had thought that this would be given to all the labor wards, and the colored printouts in the labor ward always are very striking. So you shout for help. Please take a 16 or an 18 cannula, not a 22 and a 24, because you have to take out a lot of blood and you have to give them fluids as well as magnesium sulfate. Place the woman on a left side to reduce the risk of aspiration, secretions, vomitus, and then assess the bleeding, that is the ABC, and check airway. Do you really need an intubation or is she stable enough? So rapidly evaluate the vital signs, and if she is breathing well and if her SpO2 is normal, you can still start off with a 4 to 6 liters of oxygen and examine the neck for rigidity. Simultaneously, one of your assistants can take the history from the relatives and find out exactly how many convulsions have occurred and have they done anything at home, have they taken her to any other place, and if she has already convulsed in front of you, clean her mouth and throat, because there'll be a lot of secretion and there's a risk of aspiration. And when you start off with the max self, you've already got that IV line. Collect blood for her blood group, CBC, platelets, sugar, LFT, RFT, and a coagulation profile. Simultaneously, get your assistant or your sisters to get this max self ready and gently catheterize the patient. Sometimes it makes sense to put in the first lot of magnesium sulfate, the loading dose, before catheterizing her, because you don't want to have a rebut convulsion immediately. So the dose I'm not going to mention right now because we're going to go through this in detail. Standard is a Pritchard regime, which IV loading dose and followed by the intramuscular 10 grams, 5 grams on each buttock, or in many of the corporate hospitals and many of the teaching hospitals today, they started giving the IV loading dose 4 grams at 1 gram per minute. And this is followed by an infusion 1 gram per hour. And then we are looking also at the antihypertensive therapy, because most of these times in this particular case, BP is high. So we will have to consider giving her antihypertensive therapy. So it may be a choice of labetalol, nifedipine, hydralazine. We'll go through that in detail. But as you're monitoring the patients, do not forget the vitals, the pulse, blood pressure, respiration rate, patellar reflexes, and a urinary output. So maintain a strict fluid balance chart, because people tend to over-infuse these patients. So make sure that we don't have a fluid overload. Provide a maintenance note. So your charts should be in place to know exactly when you've given the anticonvulsant, that is the Maxelf, and the antihypertensive drugs, and auscultate lung bases for RALs, because that is an indication of pulmonary edema, and then plan the delivery. So the investigations I've already mentioned, all these will be done. I'd like to add on LDH to this. It was not mentioned earlier times, but now we've realized that rise of LDH and early rise of LDH is an indication of the HELP syndrome. And when a massive rise is there, you know that the HELP syndrome is on, you're going to start off soon. So then you have to plan your delivery and probably expedite delivery in those situations. And we have added on a serum electrolyte as well as a PCR to that. Now, the collaborative eclampsia trial has clearly said that Maxel is the drug of choice. They had studied Maxel versus diazepam, Maxel versus phenytoin. So 52% risk of reduction of the recurrent convulsions, and 7% lower risk of reduction of recurrent convulsions as compared to phenytoin. So world over, in India, 87, we had started using magnesium sulfate, but it required the collaborative eclampsia trial to tell everybody that Maxel is the gold standard. And how does it act? It causes a cerebral vasodilatation, blocks the NMDA receptors in the brain, thereby reducing the calcium influx, alters the neuromuscular transmission, and protects against neuronal damage. Very, very important effect of magnesium sulfate. And it does cause arteriolar vasodilatation. It does help in reducing blood pressure, but it is not an antihypertensive drug. And of course, when you're using it along with the calcium channel blocker, we are okay. Earlier times, people used to worry about using Maxel and nifedipine together, but no, today we are not worried about that. You can also use nifedipine Only thing we suggest is don't use sublingual because it causes a precipitous fall in the blood pressure. So you have to use it orally. So in a patient who is probably not able to take anything oral, we probably have to just consider giving Maxel and other antihypertensives. So how do you prepare the drug? Today, we advise everybody to keep a 50% weight by volume, much more easier to calculate for the staff nurses. 4 ampules of 50% weight by volume, and each ampule contains 2 ml, so that is 8 ml, which is 4 grams. 4 grams diluted with 12 ml in normal saline, given slowly because you don't want to have a respiratory arrest. Look at the clock, 15 to 20 minutes, and once you've given it, that is your loading dose, and then you decide whether you want to go in for a continuous Zuspans regime or you want to go in for the Pritchard's regime. So if you're giving the Pritchard regime, a very important point is the betadine solution should be used to clean the skin over the buttocks, and it should be a deep intramuscular injection. There is a lot to be given, 5 grams. 10 ml is a lot of injection to be given, so it has to be deep intramuscular on both the buttocks, and it is advisable to use 1 ml of 1% xylocaine because there's a lot of pain when you're giving it, and sometimes giving that intramuscular shot can also evoke a convulsion. So therefore, the IV loading dose is very, very important. And remember, your eclampsia trolleys should be stocked with the antidote, that is calcium gluconate, because that 10 ml of 10% solution over 10 minutes can counteract the overdose of Maxel. And of course, an ECG monitor should be available, maintaining airways and oxygen. So this is what our eclampsia kit concerns. And in busy maternities, it is duty of the main staff nurse as well as the chief registrar to ensure that adequate amount of Maxel syringes, distilled water, and the cardiac capsules are there. And of course, the Foley's catheter, which is very important. So this is a list. The scissors, sometimes you have to go running for scissors and tapes. Keep everything ready. 3 ways, the collection bottles and the mouth gag, all should be in the eclampsia trolley. And today we want to tell you about something very nice, which has now come up. The Blisson have come on with this IV Maxel. This is a real savior because it is all ready. Nobody has to calculate. Nobody has to break ampules. Just open up this particular product, IV Mag. And I thought this was very, very useful, particularly in the emergency rooms. Just get it ready. The advantage is there are no manual errors. It's a time saver in critical situations. No dumping of sodium, and it's convenient for the paramedical staff. And of course, we know all the roles of Maxel. I'm going to talk to you about that a little later. But also Maxel serves in, if you're giving a Zuspans regime, you have a ready-made dose, continuous infusion for 1 gram per hour. So you have to have your, the IV infusion pumps so that this is used. So this is what exactly it looks like. So whether you're using a Pritchard's regime or whether you're using Zuspans regime, in both cases, you need a maintenance therapy. So in the Pritchard's regime, after the loading doses are over, you have to give 5 grams every 4 hourly on alternate buttocks for 24 hours after the last convulsion of the delivery. And in the Zuspans regime, the infusion maintenance is 1 gram per hour and again continues for 24 hours. So the principles are the same, only the modes of giving are different. The advantage of the Zuspans is it is less painful, and in places where there is facility of monitoring, it's much more easier. But Pritchard's is what we used to give when we were working at Sion Hospital, and many a times it still continues in the medical colleges. So patellar tendon reflexes, I've always said that if you can't elicit these, sometimes legs are very edematous and it is difficult to lift up this. You can look at the biceps, the supinator or the triceps reflexes. You can look at the ankle clonus, because if you're not able to elicit this, it means that the patient should not be immediate. You give the loading dose, but after that, you shouldn't be continuing till you've elicited these reflexes. Respiratory rate should be more than 16 per minute, and urine output should be 30 ml per hour. And always check, is the catheter properly inside? Sometimes you may get a zero output, but that may be because the catheter is blocked. And of course, it may be because the patient is in hypertension. As it is in eclampsia and pre-eclampsia, the third space tends to get compromised. So be very, very careful about that. Now, if you've given your Maxel and the convulsions recur after 15 minutes, you can repeat 2 grams of 50% again over 5 minutes. common side effects is flushing, nausea, vomiting, muscle weakness. But remember, if the patient is getting drowsiness, confusion, make sure that you have not given it very fast. And there can be drug interactions with general anesthesia and diazepam. So be very careful. And this is the chart which everywhere is being used: the pulse, BP, respiratory rate, urine output, the fetal heart, magnesium sulfate dose. And of course, once you've given the Maxelf, check, do an internal examination to check what the Bishop score is and what is the presentation of the patient. Now, when you want to maintain a level of 4 to 7 milliequivalents, that is the right dose, in this situation, it is perfect. But if you find that the patellar reflex is disappearing, mind you, a pre-existing patellar reflex now not being elicited is a first sign of toxicity, which means your level is crossing 8. If the uterus gets totally relaxed, it is 8 to 10. And if there is a respiratory depression seen by the falling down of the respiratory rate, it means your levels are going higher. So please stop Maxelf at that time. So do you really need to do a serum magnesium level? Well, it is done in the Western countries, but in our setups, it is not always possible. So, and they have not been shown to be superior to clinical monitoring, but your clinical monitoring, no shortcuts at all. And even when you're giving Maxelf for neuroprotection in preterm labor, you still have to elicit the patellar reflexes. So this is what I've already mentioned to you. If there are absent patellar reflexes and the respiratory rate is normal, just withhold the Maxelf till the reflexes return and restart at lower doses once the reflexes return. If the urine output is less than 100 ml in 4 hours and if there are no other signs of toxicity, reduce the dose to half, but after checking that the catheter is intact and is in situ. If there is a respiratory depression, which I've already mentioned, immediately stop the Maxelf, start the oxygen, maintain the airway, and give the antidote, the rule of 10, which I've already mentioned. And friends, I've already said this time and ago, those who are working in busy maternities, residents should be well trained for doing an intubation and ventilation, because in case of a respiratory arrest, that is what will save the patient. You stop the Maxelf, do give the IV gluconate, and continue to ventilate the patient till the normal spontaneous respiratory respiration is established. 13% of women will have recurrent seizures despite giving the proper Maxelf. As I've already talked about the 2 grams of IV which can be given. But sometimes you have to think and wonder, if the patient is not responding, could there be some other cause? At Sion, we had 3 patients who had not responded. One of them had cerebral malaria. The other one had a space-occupying lesion because of a tuberculosis. And the third had cysticercosis in the brain, and they were not responding. So those situations, we've already initiated a physician's advice, and they have started off with phenytoin. But in these patients, supposing they're not because of the HDP causes, that is the hypertensive disorders, if you've given Maxelf, there is no harm done at all, but then they switch over to phenytoin or diazepam, and benzodiazepine, barbiturates are used as, secondary line where the patient is unresponsive. And of course, in status eclampticus, I've seen only 2 patients in my entire career where they just didn't respond, and these patients had to be intubated and we delivered them. Levetiracetam and valproic acid are other alternatives, but they are more, situations where the patient has had a coexisting myasthenia gravis. So in those cases, you have to be very, very careful when you are giving magnesium or phenytoin, because that can cause a myasthenia crisis. So what is the specialist advice over here? If the patient is having recurrent seizures, yes, please take a physician's opinion and evaluate if the patient is stabilized. After giving whatever drug you're giving, evaluate neurological imaging, because there could be something else sitting in there. And, you shouldn't be just going up the wrong ladder, and therefore take the physician, the expert specialist input. If there is a blurring of vision, there could be a retinal artery occlusion, or it could be because of eclamptic convulsions. And we've seen patients where they've lost their vision completely because of the retinal detachment. But fortunately for the patient, it came back once the blood pressure came down. And magnesium sulfate has a neuroprotective effect, but it is in the newborns. And here again, I'd like to say that we must now have started off the antihypertensive therapy because you want to prevent stroke and the cerebrovascular accidents. And of course, the antihypertensives are there in severe preeclampsia when you're considering prolonging the pregnancy for steroids or for giving and sending the patient for in utero transfers. But in cases of eclampsia, you must consider delivery because antihypertensive therapies do not change the pathophysiology, they just buy a little time. And what should be our aim? We shouldn't be panicking and trying to get the BP down very fast. Our goal is to get a gradual control, and rapid reduction may cause a severe organ perfusion. Remember, we have a baby sitting in there. So you want to be very, very careful. You don't want an infarct or you don't want ischemic changes in the mother also. So reduce the diastolic pressure gradually over a period of time. And you can, once the patient is stabilized, you can take oral medications. And patients may have pressure-induced natriuresis, so consider volume repletion to prevent sudden precipitous drops. So in cases of antihypertensive crisis, we have labetalol, nifedipine, and nicardipine, which has entered the armamentarium now. Labetalol, there are various regimes, but the one which is followed commonly, 10 to 20 milligrams IV, and then double the dose or repeat 20 to 80 milligrams every half an hour till a maximum of 300 milligrams. And the infusion rate should be 1 to 2 milligrams per hour. But remember, please check the pulse rate, because if it is more than 100, only then can you give labetalol. If the pulse is less than 100, then please do not give labetalol. Give nifedipine 10 to 30 milligrams, and you can repeat in 45 minutes if required. The other concerns in labetalol are if there is asthma, diabetes, cardiac failure, then again labetalol cannot be used. But nifedipine has got a very nice relative in its family, nicardipine, which is initially used by the cardiologist. Initial infusion rate is 5 milligrams per hour every 5 minutes to a maximum of 30 milligrams per hour till the desired BP is achieved. And the advantage of this is it is available as an IV drug. It is 100 times more water soluble than nifedipine, so easily given IV, and it is titrable. And remember the principles again: lower the BP promptly but slowly. And remember, all these are category C drugs, but then you have to justify the benefits versus the risks. So nicardipine I've already mentioned to you about. The only contraindication is aortic stenosis, unstable angina, or a compensatory hypertension. And if there's a liver or a renal impairment, be very, very cautious. And hydralazine, this is the drug which is available only in the ICU setups. It's not available in our labor wards. It causes a direct relaxation of the vascular smooth muscle and causes a sudden drop, but is not carefully given. And therefore, if you're giving it, it has to be done with absolute cautious monitoring. And if you give it very fast, if the BP suddenly drops, the patient can have a transient hypertension, tachycardia, and a severe headache. So you give this drug only if you want to buy 10 minutes, 15 minutes, 20 minutes till the anesthetist arrives and you've decided to do a section. NTG is another drug which is now being used for hypertensive emergencies in patients with eclampsia and acute pulmonary edema. This decreases the preload by venous dilatation, and the dose is 0.25 to 5 micrograms by infusion, and gradual increase. This again causes a severe headache and tachycardia, and you need to have an ECG monitoring. Safdarjung Hospital and AIIMS use NTG even in the labor wards because their residents are trained for the ECG monitoring. But once the BP settles down, you can switch over to the standard preparations. Methyl dopa is no longer available. So now you have to think of delivery. What factors will make you deliver this woman urgently? And if you decide to wait for 48 hours, how would you monitor her fetal and maternal well-being? And if the BP settles to 140/90, would you wait or would you deliver her? The most important thing is if she's severe preeclampsia, you can buy a little time if you are considering in utero transfer. But if she's already convulsed, please consider delivery. Even if she's 32 weeks, you can buy time to give her steroids. You can buy time to give Suchitra to the in utero to the tertiary care center. But remember, you have to consider delivery. So you decide about the need and the urgency to deliver, assess the patient's general condition, and check the gestation, presentation, and position, do a vaginal examination for the Bishop score. And most of the times, patients who have convulsed, they would probably be in labor and they would already be, good Bishop score. So all that you have to do is just accelerate the labor, break the waters, check the meconium, and start off with the Pitocin if the patient is well settled. But if there is a preterm severe eclampsia, the patient is maybe 30 weeks or 31 weeks. Usually in these situations, the Bishop score will be very poor, and most of the times the presentation will be either breech or oblique. So in this situation, you have to consider cesarean section, but talk to the relatives, because the patient may not always be able to speak at such times. Talk to the relatives. So here you have to have a good NICU, skillful delivery backed with experience, because here the lower segment is not very well formed at all. But there's no rush. Stabilize the patient, give her Maxel, get her BP down, and only then consider delivery. However, if the patient is preterm and if she's already in labor, say 4 or 5 centimeters, and the fetus is in cephalic position, you can try a vaginal delivery. But in the case of a breech, then it is not exactly a great option to deliver a preterm breech, particularly if it is 31, 32 weeks, when the weight is more than 1.2, and NICUs can salvage these particular babies. Now, in eclamptic patients, if the patient is already in labor, in the process of labor, we've had such patients at Sion where the patient is actually convulsing and she's in second stage. Please give her the loading dose of Maxel. Start off with the Maxel and then, allow her to deliver. But remember, she may convulse again. Therefore, giving that Maxel is very, very, very essential. Now, how do you optimize neonatal outcomes in preterm deliveries? If the woman has got a severe preeclampsia, in these situations, you can give her Maxel for neuroprotection, you can give steroids, and you can consider transfer to a center with a better NICU. And obviously, betamethasone is a good salt, but there's a shortage. And in those cases, you can give Dexa, 12 milligrams, 24 hours, or 12 milligrams every 12 hourly. Optimize the time because you want to get the best possible outcome. Magnesium sulfate gives a good neuroprotection between 26 to 32 weeks from whatever evidences have been available. And at Surya NICU, which is one of the biggest NICUs, we regularly give this when we have patients coming in at a preterm gestation. And of course, the MAGPIE trial has mentioned about prevention of convulsions by giving magnesium sulfate. And therefore, we do consider that. Anesthesia choice, always regional is better, unless the patient is convulsing or is a status eclampticus where you cannot give a spinal. Otherwise, give a regional, because GA is not exactly easy, difficult intubation. You've already given Maxel, there may be drug interaction. So skillful, experienced team of anesthetists should be available. And obviously, regional is contraindicated if the platelet counts are very, very low, which means the patient is in DIC already. Now, once the patient is delivered, your job is not over. You've handed the baby over to the neonatologist, but please keep this patient in the HDU. If you don't have an HDU, put her in the ICU setups, or keep an HDU, wherever the maternities it's possible. Please establish an HDU according to the government guidelines. You have to look after the BP because it may not come down immediately. It may take 4 to 7 days for it to come down. Sometimes the BP drops down after delivery, but rises again after 4 to 7 days. Make sure you've evaluated the cardiac status. As Sharmila very rightly pointed out, there could be some pre-existing cardiac problems, and these are the patients should be monitored. There should be a cardiac consultation. And in fact, we also advise a 12D DCG and a 2D echo. Find out the cause of the BP. It could be autoimmune causes, particularly if it is preterm eclampsia or preeclampsia, but rule out, sometimes it could be a kidney problem. So make sure you've done the renal Dopplers, not immediately. Wait for, till the patient's BP settles down. And if there is a renal problems, please take a nephrology opinion. Sometimes the patient can be discharged if she's settled down after 3 to 4 days, but call her back for monitoring or advise domiciliary monitoring. Many of the patients today buy the BP apparatus and do it, or if they're in a smaller place, the ASHA workers can do it, or if they're in a medical college setup, they can be called back and soon consult not just the patient, but also the relatives for lifestyle changes and contraception. Many a time these patients conceive within 6 to 8 months, and it is risky for them as well as their life. So time and again, keep talking about contraception and preconceptual counseling if they want a child in future. So coming to the last slides, the complications of eclampsia: respiratory failure, renal failure, liver failure, and the posterior reversible encephalopathy. So prevention of convulsions is very important. Most of the cases of breast will resolve in a couple of weeks, but they require an ICU setups because they've got a lot of angiogenic edema. Particularly with MRI and CT, you can find out the parieto-occipital lobes will have that big hyperintensity, and the main treatment is discontinue offending medications, lower the blood pressure with labetalol, nicardipine, or nifedipine, give them Maxulf. If not Maxulf, if they have got some other cause, phenytoin or benzodiazepines, correct the coagulopathy. The vasogenic cerebral edema will gradually settle down. Quite a few times these patients are also given mannitol to reduce the cerebral edema, and if required, a temporary renal replacement therapy, a hemo or a peritoneal dialysis is given. But remember, these patients of breast respond beautifully to their treatment, and within 4 to 5 days, they can be brought out of the ICU. So don't forget, don't just give them up as given cases. So the last slide, prevent preeclampsia. Today we have predictors, and Charmila has given such a beautiful, change of plans. Think of all those plans, but detailed history, weight, BP, gestosis score. If the gestosis score is 3 or more, start aspirin and calcium 1000 to 1500 milligrams in low resource settings. If a first trimester scan is possible, do the 11 to 13 weeks. And for this, you require training. Just because you have a probe doesn't mean you can do this. And an EVICO screening, which is an advanced screening where you're looking not just at the PAPE, but you're also looking at the PAPE as well as you're looking at the placental growth factor. So the low PAPEs are predictive of FGR, but if the uterine artery Dopplers are high, low PAPE and a high mean arterial pressure, and along with the ESPRAY trial, if you have got a positive result, please start off with 150 milligrams of aspirin if it is not already started. And this is to be taken at 8 or 9 o'clock at night. And remember, you can use other biomarkers too. Encourage regular follow-up, domiciliary BP monitoring. Don't just shove them off. Monitor these patients, monitor fetal growth, and impress upon them that they may need an early delivery. So they should come regularly for the follow-up. And finally, once they've delivered, talk to them about contraception, lifestyle changes, particularly obesity. Typically obesity, PCOS. These are the patients who are also probably on statins before they've got pregnant. These are the typical patients who will develop convulsions, preterm convulsions, as well as atypical, preeclampsia and convulsions. So remember, Maxulf is a fantastic drug. Again, these charts I'm telling you about, please take a printout, put it in your labor wards. And don't forget, this is a superb, innovation which has come, and it is not expensive. Think about this. Thank you very much. And once again, thanks to the MOGS team, Dr. Pardesi, Dr. Sujata, and Dr. Pratik for giving me this opportunity. And thanks to Dr. Bharti Maheshwari for chairing my session. Thank you.
Thank you. Thank you, Dr. Suchitra, madam. It was really excellent lecture. Each and every word was useful. And really, it was very comprehensive, practical, very useful. And I think nothing left to say by anyone else. Everything is covered. And the last 2 lines, just I want to highlight that all residents and all postgraduates, they are just attending this, and we see lots of eclampsia, preeclampsias daily in in UP and in the other areas. They are still there, and even from periphery, they are not having so much of care what they should get, and they are refer in the bad position. So I always say that we are encouraging and we are emphasizing. Then first, as you have said, that every pregnancy should be planned. So before pregnancy, preconception care really have role in the prevention the complications, eclampsia, as well as managing the chronic hypertension. Blood pressure should be controlled before pregnancy. And second thing, we almost remain alert for the high risk cases and how we should monitor and do surveillance so that further complications can be minimized. And as madam has you have said that we in the we are at the periphery Muzaffarnagar, we are having the now 15 beds very good obstetric HTU. So government is doing very well, and NMC has done the clearly guidelines that every hospital should have. So this is really boon to us that now such patients we get good emergency care, as well as you said, that it is really eclampsia and such complicated cases we are doing with multidisciplinary approach. So they should be referred timely if we don't have, and then we should have a good critical care of these patients. So, and what you have told about IV mag and MEC self kit and eclampsia kit, so that is very important, because when patients come in emergency, then the initial treatment, that is very important, how we give in time and how quickly we give. So that is very fantastic. So again, thank you, Dr. Pratik Tambe, that you have invited me, giving me opportunity to, listen these two good lectures, and giving opportunity, inviting to sharing this session. Thank you.
Thank you, Dr. Bharti Maheshwari, and hats off to Suchitra Madam. Dr. Suchitra Pandit, for those of you who don't know, was the person who co-opted me into the Mumbai Society. And thanks to her for giving me this platform. That's why I'm here in front of all of you today. All of whatever my journey has been thanks to her as my teacher for giving me that first opportunity many years ago. I'm sharing my screen, and here on the screen, you will see the Foxy ICOG Gestosis score, which is part of the Foxy ICOG GCPR, which we did in association with Dr. Suchitra Pandit and the Gestosis organization. This is the score which was devised by my dear friend, Dr. Gorakh Mandrupkar from Islampur. We will have him one day probably to talk about this Gestosis score in a future activity. Of course, this was validated and devised by an expert committee with Dr. Sanjay Gupte sir, Dr. Suchitra Pandit ma'am, Dr. Alpesh Gandhi, and Dr. Girija Bagh, along with Dr. Gorakh Mandrupkar. So this is the score, as Madam rightly pointed out. It's already available as an Android app. It's there on the Play Store. This is the committee which was instrumental in forming this entire GCPR, and this is available for free download on the Foxy website as well as on my website. I think there is a small announcement from the Science Integra team. Can you please go ahead and share the screen? So this is breaking news. We have over 130 questions that are waiting for our eminent speakers, and we have a record registration of 1,245 audience, not only from India, but from across the world. So my hats off to the entire Science Integra team, Subbu, Sana, Ganesh. Thank you for all the hard work and effort that you've put into organizing this program, not only during the event, but also in the back end. They worked very hard to disseminate the information about the entire program. And of course, our academic partners, Blisson, who are the manufacturers of IV Mag. Before we go on to the questions, if Dr. Sujata Dalvi would like to make any comments, I see she's still logged in.
But I think, Pratik, everybody has already made a proper comment, so it's okay from my side. It was an excellent webinar, that much I can just tell you, and lots of information given to those who have logged in.
Thank you so much. So we'll just take the questions which are relevant. Many of the questions which are there have already been addressed by our eminent speakers. I'll just pick up a few which have not been addressed during the talks. One of these is from Dr. Pooja Baranwal from Amethi, and she's asking, is there any role of prophylactic dose of magnesium sulfate in severe PET. I think what she's trying to ask, Suchitra madam, is about intercurrent eclampsia and intercurrent magnesium sulfate, which we used to give once upon a time. Is there any rule for it today?
No, intercurrent eclampsia, now we don't believe in that. But what probably she could also be meaning is, referring to the MAGPIE trial, which I talked. If the patient has got severe preeclampsia, we can give prophylactic Maxel. You give it the same way, the loading dose, and follow it either the Zuspan's regime or the Pritchard's regime for 24 hours, because this will prevent eclampsia. Today, if the patient has got severe preeclampsia, I am treating her. But if she develops convulsions in front of me, then somewhere I have faltered in my treatment. So I must give her Maxel. So that if that is what she's meaning, yes, you can give prophylactic Maxel, but intercurrent eclampsia, now no. Once a patient is convulsing, you have to deliver her. There is something grossly wrong in the pathophysiology, and it's better we deliver her rather than continue the pregnancy.
Thank you, ma'am. The next question is for Dr. Charmila, ma'am. This is Dr. Mayuri Shinde Joshi from Amarner, and she is asking, what are the basic investigations which can be done in a low resource setting in rural places for patients to triage hypertensive disorder?
Every system has to be investigated. So if you want to do only for a liver function, AST-ALT for the liver enzymes, because after that elevates, then only the bilirubin goes up. So that enzymes you should do. A platelet count is mandatory. Platelet count is normal. You need not do a coagulation profile. A complete blood count is mandatory because you need a peripheral smear to see whether any hemolytic complications have started. So a CBC, urine albumin that we have in most of our centers, we're not able to do the spot protein creatinine ratio, at least a urine albumin for the renal, for the hepatic AST-ALT, and for the hematological system, a platelet count. If the platelet count falls, then you have to go for the entire profile, and a coagulation profile is also mandatory at that point.
Remember, during my residency days, 25-30 years back, we had a registrar who used to make us do BTCT serially,
Yes.
Almost every 2 hours, 3 hours, because getting access to fibrin degradation products and platelet counts sometimes in periphery becomes quite difficult. So it was a simple, easy bedside test. I don't know how relevant it is today.
The clot retraction also we do.
It's a better test.
Append and check.
This is from Dr. Muhammad Habibul Haq. He's from Guwahati, and he's saying that in rural areas, sometimes patients don't want to get admitted after giving them oral labetalol if the BP doesn't fall. Then what medication can be prescribed? I think it's probably an indication for admission.
Absolutely.
And a referral to a higher center.
And yeah, you have to titrate the dose. One single dose of labetalol cannot control the BP. It has to be titrated. And sometimes even with labetalol, you don't control. So you have to add on nicardipine or nifedipine depending on the situation. But admission is mandatory. I think, a lot of public forums have to be there to tell women that the incidence of hypertension, diabetes is so high in our country. So they should be, made aware that in case, lifestyle changes are important, but in case an admission is required, don't worry about that, because your life is more important. Once you live, you can give best to your family. I think there's always the cost issue, which they're worried about, transport to another place. But, then this at the risk of losing lives. I feel bad today when we are still having maternal deaths due to eclampsia.
We did a data collection of rural health women here in self-help group women, the age group of 25 to 40, and we picked up 30% undiagnosed diabetes and hypertension. That's a high in the rural population. It's not even urban.
Not even urban.
Self-help group women who work physically. There's a 30% incidence of diabetes and hypertension. So you can imagine the problems which is happening in the rural areas.
Yeah.
Diseases of the modern age. I think that's what
and
you
NCDs
highlight.
are very, very high in India, so we have to work on a war front, absolutely war front, to get both these problems. And Pratik, I wanted to mention over here, today when we are talking PCO as a problem, PCO is actually an underlying problem of a metabolic syndrome. That metabolic syndrome where, triglycerides are high. And these women, again, if obesity is there, even if they're not obese, even if they're thin, the incidence of preeclampsia is found to be higher. That correlation, there's a lot of work going on this, but even in our gestosis score, PCOS is one of the risk factors.
Yes, ma'am. And in fact, last month I was reading about adolescent PCOS, and there are many patients who present with acanthosis nigricans and metabolic syndrome as the presenting symptoms
Yes.
of PCOS. And those women, when they go on to get pregnant, they are going to have probably 10 or 20 times greater high risk factors for not only gestational diabetes, but also for eclampsia. So now we have this question from Dr. Prerna Chandak from Akola. She is originally studied in Mumbai in SIAM. I remember her. Her question is how to manage severe oligohydramnios at 26 weeks in PIH patient. Charmila.
Oligohydramnias, once you picked up fetal growth restriction, it becomes Doppler management. So if the mother is doing well, you have controlled her blood pressure, she's not gone into severe any organ dysfunction, you want to continue the pregnancy, the management of the baby will depend on the Doppler studies. If there's going to be a reversal or it's going to be bad for the baby, you need to deliver her. Other than that, for growth restriction, you don't have any particular management which will prolong the pregnancy. It's just like you want the baby to survive, so give steroids, give Maxel, which below for 34 weeks, and see how the mother is controlled. Mother is not controlled, the mother takes precedence, so she will be delivered. If the mother is doing well, the baby's Dopplers will tell you when you're going to deliver.
Thank you, ma'am.
Pratik, I'd just like to mention here that, when the Dopplers, in the urban setup, some of these fetal medicine people are so good at their Dopplers. So they have gone into a completely different classification. Even at the first, second, and third centiles, we're able to prolong pregnancies with small babies just because their Dopplers are doing well. There is no evidence of fetal hypoxia or, there's no acidosis. And they say, okay, now the point of delivery will be determined by ductus venosus or by the change of the CPR. So, those are of course, these are not available at all places, but those really help. And just to add on one more thing, I know what Charmila says is very right, that there's nothing else which is available, but we still use a lot of L-arginine and, left lateral position, tell them to improve their diet, tell them to, thoda sa change, whatever that can happen. Small studies have said that L-arginine helps. We don't have a big RCT to say that, but for the want of something, please, that can be tried for a little when you want to buy a little bit of time.
And Dr. Samatharam talks about hydration therapy. He says drink lots of water and it will flush out the immunological substances.
Yes, Samatharam had talked.
And he has done actually it seems to be an RCT as compared with a placebo. So probably lots of water in a low resource setting. Ask them to drink from the early days only. He says he gives them bottles of water and they have to make sure that they finish by the end of the day. Probably.
Those of us who work in ART, we are very fond of sildenafil, especially when it comes to fetal growth restriction.
Right.
There's this question from Dr. Vijaya. She's from Chennai, and she's asking the role of placental growth factor in prediction of preeclampsia. I think, Suchitra, madam, you mentioned this in passing.
Yeah. It's important to, today the Evico screen, the advanced screen is available with some of the companies. One of them I know is Lilac has got that. They look at the PLGF factor and they actually calculate and tell you this is a risk of, preeclampsia in the pregnancy. So it is important to do that because a placental growth factor does start dropping in preeclampsia, pregnancies. So quite a few times they do a risk ratio of S-FLIT versus PLGF. And then, that ratio will tell us what is the predictive factors. It is converted into multiples of median, that is the MOM factor, and that will give you a risk ratio. So that is, of course, where it's possible. Now in Mumbai, in Delhi, in bigger places, it is available. It costs about 2,000 rupees for that entire test. And if you're doing the first trimester screen, it'll, there'll be an additional, if it's 5,000, it will be an additional 2,000 more. So 7,000 rupees, and that entire Evico screen is available. In Ireland, where they've done the Parrot trial, they are trying to see if women can be, at the emergency room itself, whether they can do this test and find out whether these women should be admitted or whether they can be sent home. And they found that when they do the PLGF ratios, if they find that the value is less than 38, then that they can wait for a little more time. But if the values go beyond 55 and 60, then they know that these women have to be admitted and they should be, vigilantly monitored for signs of preeclampsia and delivered as soon. But, the Parrot trial, the Parrot 2 has now come in. So we'll have to see what the results of the Parrot 2 trial are.
Thank you, ma'am. That's something which even I probably need to look up because I've not heard of it, very honestly. What I'm aware of is this FMF, Fetal Medicine Foundation first trimester prediction model, the one which talks about mean arterial pressure,
Yes.
uterine artery, PI, and the placental growth factor. And they found that the first trimester, they have more than 90% prediction thanks to using this. And this is validated data from good RCTs. So maybe that's also something that we can easily implement and should not be all that expensive, rather than just relying on that rollover test and all those ancient tests which we read about during our undergraduate years. One last question we'll take, and this is from lost it here. Yeah, this question is regarding giving oral magnesium antenatally to prevent preeclampsia. Is there any role for it? Sharmila, can you throw some light on this?
No, I don't have an idea of oral magnesium for.
This is Dr. Monica from Lucknow, and she's asking, is there any role for this to prevent hypertension? Because calcium, of course, we give.
What has been said, WHO has said, calcium poor setups, meaning the resources where the diet is deficient, you give calcium and magnesium combination together, 1.5 to 2 grams, and that will help, along with the low dose aspirin, that will help in reducing the preeclampsia. But it is not an individual magnesium alone, it is a calcium magnesium combination which is given.
Okay, that's something which I think we can think of, because it would be easy to implement that actually.
Only thing is that the tablet becomes very big.
No, during COVID, we took magnesium, no, madam. Actually, my nails and all improved.
Yeah.
I don't know whether it has any significance.
Yeah.
I think all of us have taken tons of zinc and vitamin C and whatnot during COVID.
But as
when we were postgraduates, people used to talk about Maxwell enemas, but I don't think it's got any role. That was more historical than anything. I've never seen a Maxwell enema being given.
Neither have I, honestly. So I think that's the end of the Q&A session. If anybody else has any comments they'd like to make, then please go ahead, or we will propose the final vote of thanks. Dr. Bharati, Dr. Suchitra, any of the faculty, if there's anything else you'd like to say before we close.
No, Charmila mentioned about metformin. So again, that goes down to the same, the metabolic syndrome, where metformin gets, it's better for conception, and once the patient conceives, you continue it because it helps the placenta and eventually probably reduces the preeclampsia. It's a wonderful study which has come with dydrogesterone. So dydrogesterone, in fact, 2 big studies which have come from Israel, where they're saying that the use of 30 milligrams of dydrogesterone, that is 10 milligrams 3 times a day, improves the placental blood flow and actually has a pro-angiogenic effect and reduces the incidence of preeclampsia. And they have done it in about 84 patients, where they've got 40 in each arm. And they found that the arm which is getting dydrogesterone versus the arm which is not getting dydrogesterone, the incidence of preeclampsia was lesser. And the second study was where they give dydrogesterone to women who had high risk factors for preeclampsia, like previous history of preeclampsia, obesity, history of PCOS, or where they were chronic hypertension. In those groups also, they found that this was much more better. Of course, the sample size is smaller, but I think there are people who are looking into doing a larger RCT for this. But dydrogesterone also, probably may be an answer to our, multiple things which Charmila has given, statins and, protein pump inhibitors. Maybe dydrogesterone could also be an entry over there.
And then assisted reproduction.
Disease of immunology in the first trimester, and that is how dydrogesterone works indirectly. Yes, Dr. Chalmala, sorry.
In assisted reproduction, it's better if you go for natural cycles for transfer rather than the artificial cycles where you prepare with estrogen and progesterone, because that has created a big number of preeclamptic cases. So giving probably a natural cycle where you can just do an artificial, like 1 HCG, get the egg rupture and then do your transfer. Probably you can reduce the hormones which you give. So that will be one method of management.
Thank you, ma'am. So I'll propose the final vote of thanks as the convener for today's program. It's my pleasant duty to thank our AMOG's office bearers, Dr. Rajendra Singh Pardeshi, our president of AMOG's, our secretary of AMOG's, Dr. Sujata Darvi, both of whom were physically present for the program. Thank you very much for being here. Our ICOG office bearers, Dr. Lakshmi Srikhande, chairperson of ICOG, Ashok Kumar sir, secretary of ICOG. Thank you so much for the ICOG credit points. For the first in the series, the experience series, which we have started this year in 2023, hypertensive disorders in pregnancy, updated management strategies. Thank you for the excellent talks and thought-provoking ideas. Dr. Charmila, our Vice President-elect of FOXI, Dr. Suchitra Pandit, my mentor, for giving us so many practical hints, tips, and suggestions on how to deal with eclampsia. Dr. Bharti Maheshwari, thank you so much for being here and gracing the occasion, giving your valuable inputs as well. I need to place on record my gratitude to the entire Science Integra team led by Subbu, Sana, and Ganesh. And last but not least, our academic partners, Glisten, makers of IVMAG and Injection I3. Thank you for placing your trust in us. Thank you to the audience who have logged in from not across India, but all over the world. More than 1,250 of you. We hope to see you very soon in the next event. Until then, take care. God bless. Goodbye for now.
Thank you, Dr. Pratik, and all the speakers for very informative discussions. And really, I enjoyed. Thank you.
Thank you so much.